let's just talk about updates. I'm really interested in the concept of summer waves, and why we have these. I think there's a seasonality to COVID, but it's still hardy enough to survive. Again, I'll start with Dr. Wallace. What are people asking you? What are their concerns? And what are you telling them? Because we are in kind of a, I hate saying this, a different place than we were, but it's nor is it like a non-issue.
Yeah, I think there's a bunch of different camps of people, right? There's people that think like, oh my gosh, COVID's still a thing and people still test for COVID. Like I think there's that camp. And then there's people that have to be cautious because they're immunocompromised or they're disabled. And this is like, the fact that everybody else is kind of ignoring it is a threat to them and their health and safety. So it's been very interesting with the kind of questions I get because I get it all over. It runs the gambit of those kind of extremes. So I think people really wonder about data a lot because we really don't have good data right now. So I try to put data on my page when I have it and when there's something to say from the sources that I have, which are not as good as what we've had in the past. And Katelyn, I'm speaking to the choir with you because you're probably in the same situation
Yeah.
with data. But so I know the wastewater is increasing. In terms of like why we have summer waves, my guess to this is just that when we get extreme temperatures, it brings people indoors and it spreads more easily indoors when you're around other people. When you're in like enclosed settings. I don't know, I'm not 100% sure. I haven't done research to show that, but it does seem that when we have times that bring people indoors, it's when we kind of get these waves.
Yeah,
I don't know.
I was doing a little bit of a deep dive on this the past few days. Nothing that I would like put in a peer review publication or anything. But
Yeah.
but what I basically, but I think what you said is borne out by the data. If you look at a place like the South, where during the winter it's still warm enough for people to eat outdoors sometimes, and it's really the summer where you have to hide from the elements and go
Yeah.
inside. And you look at a place like in the South where the summer peaks and the winter peaks aren't that different. Whereas in a place like Massachusetts, where it's like summer outdoors, winter indoors, our winter peaks are much worse than our summer peaks in terms of just like hospitalizations and deaths, and also I think wastewater. So, so yeah, I think that's absolutely the case. Let's talk about long COVID for a second, because I know our readers and listeners and watchers are very concerned with this. Did you see the new paper in the New England Journal from Dr. Ziad Ali and his team at the VA?
I did. How could you not see
Yeah.
it? It was like every headline in every news organization. But yeah,
This is what we do,
that,
but our
that is
audience
true.
actually,
Yeah.
our audience has a lot of our audience has a life. Uh,
Oh, really? What is that?
so what did you take away from that?
I wasn't surprised. I think that it follows the data we've been seeing, that the risk of long COVID is declining over time, both because of immunity and because of changes of the literally changes of the virus. Um, but there's still risk. And we don't know what the future is going to show. If we hit some sort of immunity threshold and there's always just going to be this underlying static risk, if it's going to continue to decrease. But I thought it was helpful for the conversation and certainly answers a lot of questions that people have out there.
Dr. Ali's team has VA Veterans Administration data, which gives you a really nice look at risk across. It's a high risk population. I want to say that.
Yeah.
Although for long COVID, it's not necessarily the highest risk, right? On one hand, I want to say, oh, don't extrapolate. This is a very sick cohort of folks. But long COVID kind of doesn't necessarily always hit just old people, and that's what the VA is pretty enriched to have. So it's interesting. But I think over the next couple of years, we're going to learn a lot more as Medicare, Medicaid claims data come out, and we start to do some really cool kind of experiments to look at what's going on. Dr. Wallace, what did you think about that paper, or anything else related to this topic?
Well, I think that the field of research on this topic is it keeps being reinforced in different populations, which is really it's helpful, right? We have the recover studies that have shown the same thing. We've shown pediatrics and adults, and now we have this other population of mostly senior men. So it seems to be replicated in all these different populations, which is hopeful. And this one attempted to actually quantify the percent of avoidance that was due to the vaccines, which was kind of cool. It was something like 72%. One thing that I kind of take, every study has its limitations and its, strengths, right? You have to kind of be a little bit critical when you're looking at any type of study, like no matter what it is. And one thing about database studies when you're talking about COVID is it's like, when you say like, okay, there's a group that had COVID and then a group that didn't have COVID, it's a little bit hard for me to believe that that group didn't have COVID at this point. For me, I'm like, well, maybe they just didn't have it bad enough to go to the
No,
doctor and they're not
that is a huge
yeah.
point.
So that's the only kind of, but like I said, it is replicating other studies. So I tend to believe it, but that's a huge limitation of database studies on COVID particularly.
All right, Dr. Jetelina has to jump off. It's probably the White House or something like that
Bye,
she has to
guys.
go to. Otherwise, but you can find Dr. Jetelina at your local epidemiologist on everywhere, on Substack and here. And thanks for joining us. Hop off, Katelyn, and Dr. Wallace. You and I can stay for another minute because that last point I think really does warrant like an extra go around. This is actually, and I really respect Dr. Ali and his work,
Oh, same. Absolutely.
and we're friendly and we talk a lot. But I think that, when people compare the comparator group in research is everything. And as you said, we know for a fact that up until the Delta era, we were probably missing half to 75% of cases. Like we didn't have tests. And then in the Omicron era, when people started doing rapid tests, we probably missed, in terms of public documentation, it could be, most cases.
And I remember that was shocking too, that there was nowhere to like call and register your positive test or whatever. Remember
Right.
that?
And look, this is a thing that's like, people were like, oh my gosh, rapid tests are problematic because we want to know where the virus is. And people like me would say, well, yes, on the epi side, that's true, on the epidemiology, but on the like, give people news they can use, and that way they can call their doctor if they need Paxlovid or something like that.
Right.
It's better to have instant results at your fingertips. And so we know, for example, that we miss a lot of cases. So therefore, and this is the point you're making, in a study that compares people who had COVID to people who didn't
And
have COVID, you
there was
probably
4.7 million in the control group. So
we know that a lot of those people actually had COVID and it was mild. And if they were put into the COVID group, it would really, really decrease the rates of long COVID. So I always say that no matter what the rate of long COVID is, it's a serious deal because no one thinks it's 0.1%. But even if it were 0.1%,
yeah.
even if it were 1 in 1,000, it would still be hundreds of thousands, if not millions of cases. And so, but I think what people still kind of question is like, well, is it in the double digits? Is it even in the single digits? Based on, they look around, they know 100 people and who has it. But I think that the answer is that it's a big enough problem regardless.
Yeah. And the problem why we don't have great numbers in terms of prevalence is that there's no one definition, clinical case definition of long COVID that exists. We've got every health agency has their own definition. There's like 10 different definitions. So the CDC has one, the WHO has one. So it's right now there's a initiative by the NIH to harmonize the definition.
Mm-hmm.
So depending on what definition each study used, or even things like how much time is considered long,
right,
in the, like, these things matter when you're kind of doing a systematic literature review and a meta-analysis, because if you're combining studies with all different methodologies and all different clinical case definitions, it's like garbage in, garbage out,
Yeah, and I will say that I addressed the National Academy of Sciences work group on this like a year ago, and my sort of
National Academy
yeah,
of Sciences, you're right.
and they came out with a definition that the CDC has basically adopted immediately. But the issue with that definition is it's very broad and inclusive
Yeah.
because they don't want to miss any cases. The problem there is it becomes harder to study therapeutics when you're not distinguishing between subtypes, or when basically they don't want to miss anyone, so it's pretty
So
broad.
it's
So I think that there's
not specific.
exactly right.
Yeah.
This idea of like inclusive is good, but it makes it harder to study, and so I think we see this hope for the future. Someone asked before we go, can we have hope? Yes, I will. Let's give them hope.
And
Here's
then
here,
positive.
yeah. Here's my favorite line. Well, if we can't end on a positive note, maybe you can just give them two negatives. No, it
I
doesn't
have some
cancel.
positive stuff.
Okay.
There's nasal vaccines that are under development for COVID, which is really exciting because that could theoretically sort of have a little bit more effect on transmissibility and
Oh
like
yeah,
mild illness,
for
right?
sure.
So that's kind of an exciting time. Hopefully the trials will go well. They're also working on combined flu and COVID vaccines for people to get them both at the same time, which I think is great too. So I think there's a lot of exciting kind of developments right now that will hopefully lead to a brighter future with all these things in the fall.
Yeah, and I'll end on a weirdly, strangely positive note, which is that I am way on record of saying I think Paxlovid was like a lifesaver in the pre-vaccine era, and that now I'm not quite so sure. I mean, there are some people who need it, but the good news is that in all the studies looking at Paxlovid, the rate of hospitalization and mortality in the placebo groups, or the group who didn't get Paxlovid, is so much lower than it
Yeah.
was 4 years ago. And so while we're not done with this, and again, a small number multiplied by 330 million Americans, or a small percentage multiplied by 8 billion humans is a lot. It's still a major problem. It's the order of magnitude of risk walking into a room has gone down.
I just want to make sure people understand the point you just made because I think it's really
Yeah,
important. In
please.
a really highly controlled study, he's saying that people that were not medicated with antivirals with COVID still had a much lower rate of severe illness, like hospitalization and death, which means like our baseline risk of those things, like population immunity and the vaccines we've had in the past, really have worked to protect us moving forward. So I think that is a really key point that you just
Yeah.
made.